Hello and welcome to another video by Medical Doodles. I am extremely sorry for the long hiatus in between. I got caught up between college work and other stuff, but now I'm back and I have a new video. If you haven't already subscribed to the channel, please do subscribe to the channel, and you can also follow me on Instagram at medical underscore underscore doodles. So let's begin. So today's video will be on a surgical topic since I'm posted in surgery right now, and today's video is going to be on goiter. Goiter is the term which is given to the diffuse enlargement of the thyroid gland. It comes from the Latin word gutter, which means throat. The classification: thyroid swellings can be classified into four broad categories, which are simple goiter, toxic, neoplastic, and inflammatory. Simple goiter may be of two types: diffuse hyperplastic or multinodular goiter. Diffuse hyperplastic may be because of physiological reasons, it may occur at puberty or it may also occur at pregnancy. Now, toxic thyroid swellings may be diffuse, for example, in Graves' disease. It may be multinodular or it may also be in toxic adenoma. Neoplastic thyroid swellings can be benign or malignant. Inflammatory thyroid swellings can be autoimmune, for example, chronic lymphocytic thyroiditis or Hashimoto's disease. It can be granulomatous, for example, de Quervain's thyroiditis. It can be fibrosing, for example, in Riedel's thyroiditis, and it can be infective. Infective can be acute or chronic, and miscellaneous causes include amyloid deposition. In this video, we will be talking about multinodular goiter and solitary nodule goiter. So we begin with multinodular goiter. Multinodular goiter is a discordant growth which has structurally and functionally altered thyroid follicles. So how does a multinodular goiter occur? Let us understand the pathogenesis. So, because of the persistent TSH stimulation, there is diffuse hyperplasia of the gland where all of the lobules are active. But later on, with the fluctuation of the TSH level, there are mixed areas of active as well as inactive lobules. So, the active lobules become more vascular and increase in number. There is hyperplasia, and hemorrhage and necrosis occurs in these active follicles, which leads to formation of a nodule. So, nodule formation occurs in all of the active follicles, which leads to a multinodular goiter. Firstly, it occurs mostly in middle-aged females. It is a slowly progressive disease. The nodules, which are formed in both the lobes and may also be formed in the isthmus, these nodules are firm, they are nodular, they are non-tender, and they move with deglutition. Recent increase in size in the nodule may be suggestive of hemorrhage or malignant transformation. And a long-standing multinodular goiter may also compress the trachea, and if the nodules are calcified, they become harder, and necrosis will obviously soften the nodules. That are done are T3, T4, free T4 ultrasound of the neck, FNAC. FNAC is done from the most dominant and suspicious nodule. An X-ray of the neck is done, which may show calcification of the nodules, and it may also show compression and displacement of the trachea. An indirect laryngoscopy may be done to see the condition of the vocal cords prior to surgery. Done. For treatment, usually surgery is preferred. When the entire gland is involved, total thyroidectomy is done. Subtotal thyroidectomy is done depending upon the amount of the gland that is involved. A partial thyroidectomy or Hartley-Dunhill is done, and in Hartley-Dunhill operation, isthmus plus one entire lobe and the opposite side, subtotal or partial thyroidectomy is done. Talking about solitary nodule thyroid. A solitary nodule thyroid is a discrete lesion or a nodule within the thyroid that is radiologically as well as palpably distinct from the rest of the thyroid. Solitary nodule goiter is of two types. It may be a toxic solitary nodule or it may be a non-toxic solitary nodule. A non-toxic solitary nodule is of further three types. It may be hot. In a hot nodule, it is an autonomous toxic nodule. The normal thyroid tissue is inactive and so it will not take up any isotope. The nodule is overall overactive. It is common in 5% of the patients, out of which 5% may become malignant. The second type is a warm nodule. A warm nodule is a normally functioning nodule and the surrounding normal thyroid will take up the isotope. That is, it is active. Common in 10% of the patients with solitary nodule, and out of these, 10% may become malignant. The third type is a cold nodule. A cold nodule is a non functioning nodule which may be malignant. The nodule will not take up the isotope, that is, it is underactive. It is common in 80% of the patients, and out of these, 20% may be malignant. Now we come on to the clinical features. It is the most common thyroid surgical disease. The commonest site is the junction of the isthmus with one of the lateral lobes. Single nodule palpable in one or other lobes of the thyroid, which is usually smooth and firm. Hot or warm in technetium 99 scan but cold in iodine 123 scan means it is a discordant nodule commonly, and these are malignant. Nodule in children and elderly may be malignant, and rapid enlargement of the nodules can be malignant. The investigations: an ultrasound of the neck will show the size, number, whether the nodule is solid or cystic. It will tell us the vascularity and the presence of significant lymph nodes. An FNAC can be done. T3, T4, TSH is done. Radioisotope study may be done. A power Doppler can be conducted to show the vascularity of the gland, and the vascularity is described in the terms of resistor index, and serum calcitonin estimation can be done if FNAC confirms medullary carcinoma. Coming on to the treatment, the indications for surgery are malignant neoplasm, follicular neoplasm, toxic nodule of the young. Other indications are nodule with obstruction, recurrent cystic nodule, or a complex cyst. A benign nodule. A non-toxic benign nodule is treated with observation without any therapy. So no hormone therapy is usually given. Annual clinical examination with ultrasound of the neck with regular follow-up is advised. If there is any increase in the size of the nodule, 20% increase or more than 2 mm increase in diameter, then FNAC has to be repeated and a hemithyroidectomy may be considered. Treatment of a malignant nodule. On FNAC, if it comes out as a papillary carcinoma of thyroid, then total or near total thyroidectomy is done. If the tumor is more than 2 cm with extracapsular spread, then radioactive iodine therapy is needed. Later on, suppressive doses of L-thyroxine can be given. If it comes out as follicular adenoma, then hemithyroidectomy is done. If histology reports say that it is a follicular carcinoma, then doctors have to consider completion total thyroidectomy. Completion total thyroidectomy is done within 7 days or after 3 weeks. For a nodule in the isthmus, isthmectomy is done. If the reports come out as medullary carcinoma, then total thyroidectomy with bilateral neck nodal dissection is done. An indeterminate nodule. If FNAC shows suspicious variety, then repeat FNAC. If the second FNC is also suspicious, then hemithyroidectomy should be done. On a frozen section, if it confirms that it is papillary carcinoma, then total thyroidectomy with ipsilateral central neck node dissection is done. Treatment of a non-diagnostic nodule. If FNSC is non-diagnostic and the cyst keeps on recurring, then hemithyroidectomy is the safest option, especially if the nodule is more than 4 cm. So that's it for today. Thank you for watching this video. If you have any queries or doubts or any feedback, or you want to request any topic, you can send an email or you can also comment below. And don't forget to like this video, share it with your friends, and do subscribe to this channel. Thank you so much and have a great day.